Hi, everybody. It's me, Dr. Sparks. I meant to do this earlier, but I was having trouble with my computer. So I just wanted to kind of talk you through the PowerPoint lecture for this week. So I'm going to try to share my screen here. Bear with me. So hopefully you've already looked through the PowerPoint lecture a little bit, but I kind of want to go through it with you and see if I can kind of give you the pearls, I like to call them, or actually I stole that from a professor of mine. I like to talk about the pearls in the lecture. And these are the things that, there's a lot of information in this lecture. So I want to make sure that you zero in on the things that are really important. Okay, so this week we're talking about the bony orbit, the eyebrows, eyelids, and the lacrimal system. So if we go through the PowerPoint here, we see that the bony orbit contains the globe, fat, supportive tissues, blood vessels, and extraocular muscles. It serves as a protective housing for the globe and as the framework for the attachments of the EOMs. Now, when you see EOMs, from here on out, EOMs stands for extraocular muscles, okay? So the bony orbit has a roof, floor, a lateral, and medial walls. There are 7 bones to the orbit. There's the frontal, sphenoid, zygomatic, maxilla, ethmoid, lacrimal, and palatine. I'm never going to quiz you on all 7 bones, okay? If you want to memorize these 7 bones and where they're located, go for it. But what I want to do is I want to point out the important bones. Well, they're all important, but the most important bones of the orbit and why they are important. So here's a nice diagram of the bony orbit. Okay, so we have the frontal bone here. The sphenoid bone is sort of in the back of the orbit. The zygomatic bone, the maxilla bone, palatine, lacrimal, and ethmoid. Okay, so this will give you an idea of where everything is. Now, let's take note here when you're looking at the orbit. So from front to back, the orbit is sort of shaped like a cone, okay? So the widest part of the cone would be the front of the orbit. And as you go back, as you head back, it kind of comes to a point or an apex, okay? So this is not a round socket, okay? The eye socket itself, which is better known as the bony orbit, is more like a cone shape, okay? So the roof, sorry, a little touchy. So the roof of the orbit is primarily composed of the frontal bone, okay? This is the frontal bone here, right here. You can feel it right under your eyebrow. Take your fingers along your eyebrow. That is the frontal bone. That is the roof primarily. Now, other bones contribute to the roof, but what I want you to be aware of is that the roof is primarily composed of the frontal bone. Another thing I want you to pay attention to is the lateral aspect of this frontal bone right here. The lateral aspect up inside here has a little depression where the lacrimal gland sits, okay? The lacrimal gland sits in the depression of the frontal bone. There is also a lacrimal bone, so do not get confused. It would be natural to assume that the lacrimal gland is housed in the lacrimal bone. It is not. Okay, so keep it in your memory here that the frontal bone right here makes up the roof of the orbit and also has a lateral depression where the lacrimal gland sits. Those are the 2 things I want you to know about the roof. The floor of the bony orbit is composed of 3 bones, the maxilla, zygomatic bone, and the palatine. The weakest part of the bony structure is the floor, okay? The floor is susceptible to something called a blowout fracture from blunt trauma. So we're going to consider the floor the maxilla, the maxillary bone, right? So I want you to associate the maxillary bone with the floor of the orbit. And the other thing I want you to associate with the floor of the orbit is that it is most susceptible to a blowout fracture. So here's what happens. You have some blunt trauma, okay? Something hits you in the eye. Remember the first slide says the Bony orbit has the globe. Okay, so let me back up. When we talk about the globe, we're talking about the eyeball itself. So whenever you hear the word globe, we're talking about the actual eyeball. So the Bony orbit contains the globe, all the extraocular muscles, all the fatty tissue, all the connective tissue, blood vessels. So there's not a whole lot of room in there. So what happens is when someone experiences a blunt trauma, that force, everything inside that bony orbit there causes a force, and the most susceptible place is the floor. So if my fingers are the floor of the orbit or the maxilla bone, a blowout fracture is when that force breaks this bone, okay? That's a blowout fracture. And you'll most commonly see that on the floor of the orbit. Again, the maxillary bone, blowout fracture, right? So that bone just breaks right there. All right, the lateral wall. The lateral wall is the strongest wall of the orbit. Again, right here, if you take your fingers right along here, you can feel the lateral wall of the bony orbit. It is the strongest wall of the orbit and is comprised of the zygomatic bone laterally and the sphenoid wing posteriorly. I will only test you on the fact that the lateral wall is the strongest wall of the orbit, and it is comprised of the zygomatic bone. The medial wall is comprised of the maxilla, lacrimal, ethmoid, and sphenoid bones. Right, so what I want you to know about the medial wall is that the ethmoid bone in the medial wall is extremely thin. The medial wall is so thin that erosions or perforations can occur secondary to sinus infections. All right, so let's not get confused here. The ethmoid bone is extremely thin. It's the thinnest bone of the bony orbit. Do not get that confused with the bone that is most susceptible to a blowout fracture, which is what? The maxillary bone, right? The floor. The maxillary bone most susceptible to a blowout fracture from blunt trauma. Do not get that confused when asked about the thinnest bone in the bony orbit, which is the ethmoid bone located in the medial wall. Okay. So this little cave, so to speak, the bony orbit is like the little cave where the eyeball lives. And so things are connected to the eyeball. So, we know, or we're going to learn, that the eyeball is connected to the brain. So there has to be some openings in that little cave for those connections to get from the brain to the eyeball. So we have one opening called the optic foramen, which is also known as the optic canal, right? You're going to learn here in this course that every structure has multiple names, and I'm going to try to be consistent so that it's not so confusing. So the word foramen just means opening, all right? So I'm most likely to call this the optic canal, right? So the optic canal on this slide is right here. It's located at the apex of the bony orbit. Remember I said the bony orbit is shaped like a cone. So as you move back to the back of the orbit, you're going to reach the apex. So right here where my pointer is circling, that is the optic canal. And this is where the optic nerve passes through the bony orbit to join the eyeball with the brain. Optic nerve is also known as cranial nerve number 2. We'll get to that in later lectures. But right now I want you to know that the optic canal is the opening for the optic nerve, right? They both have the same name, optic canal, optic nerve, so that should be pretty easy. There's also another opening called the superior orbital fissure. Fissure is another word for opening. So this larger opening here, if you see my pointer, that is the superior orbital fissure, and several of the cranial nerves will pass through this opening. And then lastly, we have the inferior orbital fissure. And this is where the infraorbital nerve runs through here, okay? The most important thing in this slide is to remember that the optic canal is the opening that allows the optic nerve to pass through. So how do we evaluate the orbit? Well, we can evaluate it with an X-ray, plain old X-ray. So let's take a look at this this X-ray right here. So this is the patient's right bony orbit. This is the patient's left bony orbit. And right here where my pointer is, does anybody have any idea? I'll give you a second to think to yourself before I tell you what that might be right there. So if you read over here, it might give you some ideas. So an X-ray will detect the presence of metallic foreign bodies. It detects orbital soft tissue in a normally clear sinus. An X-ray will also detect displaced fractures from some bony elements. So let's go up here to number 2. So it detects orbital soft tissue in a normally clear sinus. So let's look right here where my pointer is. See this dark area here right under this bone? Now this bone, we just had this discussion. So this bone where I'm pointing to, my pointer, everybody should know because we just talked about it, what this bone is called. This would be considered the floor of the orbit. So what would you imagine this bone is called right here? So if you're thinking maxillary bone, you are correct. So the bones in an X-ray are nice and white, like you see all around here. But here, this dark area is a sinus, right? So in an X-ray, sinuses, which should be just dead space, right? Open space, are going to look dark like this. And this sinus right here is called the maxillary sinus. Imagine that, right under the maxillary bone. Here's the maxillary sinus, and that's why it's dark, because nothing's in there, all right? We'll get to that in a minute. Let's go back to this little spot right here. Anybody have an idea what this is? So an X-ray will detect the presence of metallic foreign bodies. This is a patient who had a BB. He was shot in the eye with a BB. And the X-ray is showing that right here. Okay, so that BB was lodged in the globe of this patient. All right. So let's talk about our blowout fracture. Again, the blowout fracture most commonly occurs on the floor of the bony orbit, and it is a blowout of the maxillary bone. So let's go over here on the right side, and this is a normal orbital floor, right? This is a normal intact maxillary bone right here. And underneath here, we see the dark area because that's a what? It's a sinus, right? So here's the intact bone, intact sinus. Let's go over here to the left. Now take a look at this. Now this is the maxillary bone, but it's not looking too good, right? This is a blowout fracture. Okay, see how the bone is sort of like in a teardrop or V shape? And then look what's going on here in this sinus. The sinus is not fully clear, right? Because the bone has broken out and is now taking up space in the sinus. Also in here in this milky white area, you'll find the extraocular muscles. Now, we haven't talked about those yet, so don't worry too much, but I'm just letting you know that the inferior rectus muscle often gets pinched. So when that floor blows out and comes back up, often it will pinch the inferior rectus in that bone. So some of this milky white, you'll see it might be some of the muscle that's attached there. We can also take a look at the orbit with CT scans. So the CT scan it's a computer processed X-rays taken at multiple angles to create slices of an object. Fractures, foreign bodies, tumor margins, and inflammatory processes can be clearly identified and precisely localized with a CT. Contrast enhancement with injection of iodine-containing dye assists in the visualization of neoplasms and inflammatory tissue. So let's take a look at the CT of an orbital fracture. Okay, so the CT scan, as we said, makes slices. So it will make a bunch of slices. So what we're actually looking at is we're looking at the head from up underneath. All right, so like here's the teeth, here's those maxillary sinuses I was talking about, here's the globe where I'm circling. Now, when we look over here, we see this maxillary bone is intact and we see a nice clear empty space for the sinus. If we look over here, we see the maxillary bone is not intact. We see the globe here. We also see some tissue here and things kind of making their way into the maxillary sinus. This is an orbital fracture, and this is some of that inferior rectus muscle I was telling you about that gets trapped in there. We can also do an MRI to image the orbits. MRI provides better definition of tissues and fluids than the CT does. It does not provide adequate bone views for a fracture, and it is contraindicated in the presence of a metallic foreign body or hardware. So that patient we saw a few slides ago that had the BB in the orbit, hopefully they would have been aware of that history. They are not a candidate for an MRI because what happens is an MRI says so in the name, magnetic resonance imaging. High-powered magnets would pull that BB right out of the eye and damage the eye on its way out. So metallic foreign bodies, any presence of any metallic sort of hardware is contraindicated for an MRI. So the take home here, I want you to know that MRIs are not so great with bones, but really good for tissue and fluid. If you wanted to see the bones and things like that, you'd be better with a CT or an X-ray. And the other thing I want you to keep in your memory bank is that the MRI is contraindicated for any sort of metallic foreign bodies or hardware. But this is what an MRI of the orbit would look like. So remember we said it's not so great with bones, but it's really great with tissue and fluid. So let's take a look at here. Again, this is a view we're looking from, under the patient. This is the brain here. This is all the sinuses. Here is the globe. This is the optic nerve. This is all the orbital fat and some of the extraocular muscles. Now look over here. This is interesting. Where my pointer. So this is the globe here. And what do we got here where my pointer is? That doesn't look like it should be there. Anybody have an idea what that might be? Knowing that MRIs do a really good job of showing us tissue and fluid. So this would be a tumor of sorts here, located in the bony orbit. We can also do a B scan. B scan is like an ultrasound, or it is an ultrasound. It's high frequency sound waves that are projected into the eye in the orbit, and the waves reflect off of surfaces or areas where the tissue density suddenly changes. The echoes can be displayed as real-time cross-sectional images of the eye in orbit. It's very useful in determining posterior segment anatomy in the presence of poor opaque media, and it also provides information on ocular mass lesions such as size, height, and internal characteristics. So what does that mean? Let me explain it here on this next slide. So this is the image, this is a B scan. So let's say the patient wants to have cataract surgery, and the usual procedure for a preoperative cataract exam is to take a look at the back of the eye, dilate the patient, take a look at the back, make sure that the retina is intact, and that there's nothing going on in the back part of the eye. If a patient has a cataract that is so dense that you cannot see through it, then a B scan is warranted. So remember, the B scan sends out these waves, and anytime the density of the tissue changes, it's going to kind of leave a mark there or an indication. So here we see an image here, and L stands for the lens. So those waves bounced off the lens. And then we see a lot of dead space here. And that's because that is the vitreous. These are things we're going to learn down the road, but the vitreous is the jelly-like substance that fills the eyeball itself. And the vitreous is pretty clear, so it really shouldn't be bouncing off of anything. The next change in density comes at the retina. That's where this R is. So the change in density is going to show up here as the retina. The next structure would be this S here, which is the sclera, and that it's also going to change density here at the optic nerve. So let's look at how it might help us image a tumor. Again, same thing. If we can't see through a cataract, we can't get a very good view, but we suspect something's going on in the back of the eye, B-scan will help us to determine that. So if you remember back here, the ultrasound went through the normally clear vitreous and bounced off the retina, where here it's going to travel through the vitreous, and before it even gets to the retina, it bounces off this structure right here, which is the tumor. And we are able to, with the ultrasound or the B-scan, we're able to tell the height, the width, and different characteristics about that tumor. All right, let's move on to the eyebrows. So the eyebrows are moved by the muscles of facial expression, and these muscles are supplied by cranial nerve 7. So the facial nerve is cranial nerve 7. And in order to be able to make my eyebrows do all these kind of movements, it is innervated by cranial nerve 7, which is the facial nerve. The eyelids, right? They protect the eye from trauma, dryness, and too much light. They also assist with lubrication when blinking. So what happens is, if my hands here are the upper and lower lids, every time your lids blink, they're kind of like little windshield wipers, right? They blink and they put a nice fresh layer of tears over the front part of the eye. The eyelids meet at the medial and lateral angles called canthi, or the canthus. So, this is the medial canthus, the lateral canthus. Plural is canthi. And the opening between the lids is the palpebral fissure, which is approximately anywhere from 8 to 10 millimeters in height. So this opening, the widest part of this opening, I'm not going to measure it over here or over here. I'm going to measure it right at the widest part of the opening between the upper lid and the lower lid. That is called the palpebral fissure. Remember earlier we said fissure is another word for opening. And anytime you hear the word palpebral, we're talking about lids, right? So the opening between the two lids is called the palpebral fissure. Approximately 8 to 11 millimeters. So let's take a look at some other structures here, right? Let's start left to right. So the lacrimal gland is hidden behind our skin, of course. And if you remember from earlier, everybody should be able to tell me where we would find the lacrimal gland. Which bone of the orbit would we find the lacrimal gland? That answer is going to be the frontal bone, right? The frontal bone right across here, across our brow, has a little depression area where the lacrimal gland sits. Over here, this angle where the upper and lower lid meet on the lateral aspect here is the lateral canthus. And then over here where the upper and lower eyelid meet at the medial canthus. Now, if you've ever taken a look really close at your eyelids and the medial aspect, you'll see those little holes. They are called puncta. You have a superior lacrimal punctum and a inferior lacrimal punctum. Okay, so the puncta are on the medial aspect. You have an upper and a lower, and they are the little holes where the tears drain. This little fleshy little ball of flesh on the medial aspect of your lids is called a caruncle. And then as we move through, let me save that for when we get to when we talk about the lacrimal system. So right now we're just talking about the eyelids. So just ignore this lacrimal sac for a second. Just make sure you're familiar, okay? Lateral canthus, medial canthus, superior lacrimal punctum, inferior lacrimal punctum. Here's where the lacrimal gland resides. And one thing that is not on this slide that we just talked about, take a look at my pointer here. If I go from the widest aspect between the upper and lower lid, that is called the palpebral fissure, right? Approximately 8 to 10 millimeters. These are things I want you to be able to name. Now, let's see, I'll talk about that when we talk about the lacrimal system. So the carbuncle, that is that small pink elevation in the medial angle. The semilunaris plica is the soft half-moon fold of tissue next to the carbuncle. This is the junction of the bulbar conjunctival and muscle tissue. The punctum or puncta are small openings in the medial aspect of the lids, which allow the tears to drain. The meibomian glands, they are located in the tarsal plate of the upper and lower lids. They secrete lipids into the tears. And the gray line demarcation, the gray line is the demarcation between the anterior lid, which is the skin and the muscle, and the posterior lid, which is the tarsal plate and conjunctiva. Don't worry, I'll break this down for you. All right, so obviously this is a picture of the lower eyelid being pulled down, and this is so that we can view the meibomian glands. All right, so each of these linear structures here within the lower lid are the meibomian glands, and we have them in the upper lid as well. So the meibomian gland openings are right here along the margin of the lid, right? For every one of these little glands you see here, there is a corresponding opening on the margin of the lid. Here we go. So you see these little waxy sort of yellow dots there. They shouldn't be there, but these are in fact the openings of these meibomian glands that reside here in the lids, most specifically in the tarsal plate of the lid. This is an upper lid here showing the openings of the meibomian glands. Now, this is a person here, this is a picture of a person who has meibomian gland dysfunction. So these caps, we call this capped meibomian glands, these are sort of hard, waxy plugs, all right? So the meibomian glands secrete the oil portion of our tears, and it should be oily. It should be, you know, clear oil coming out of there, not this hard, waxy sort of plug. This is meibomian gland dysfunction. This patient is not getting the right amount of oil mixed into their tears because of this, because the meibomian glands are, in fact, clogged. So what we would do is we would take, you can use Q-tips. You put one Q-tip on the underside of the lid and the other Q-tip on the upper side of the lid, and just kind of squeeze along there. And we have to express all that material, kind of get it moving. It's kind of gross. It comes out like toothpaste sometimes. And it's, yeah, that's not so good. All right, so let's talk about the lacrimal system. All right, lacrimal gland, right, up here in where again? The frontal bone. Lacrimal gland hides up here in the frontal bone. The lacrimal gland is going to secrete the aqueous part of our tears, or the liquid part of our tears. So the lacrimal gland produces the aqueous, or the liquid part of our tears. They go into the eye. As the eyelids blink, we put fresh tear film over the front surface of our eye. Also, as the eyelids blink, they have a slight medial action. So they slightly push the tears not only across the eye, but they start to push the tears towards the medial aspect of the lids. Why is that? Because the medial aspect of the lid is where we have the inferior and superior puncta, right? Inferior and superior puncta as we blink. So I have my little puncta here, upper lid and lower lid. As we blink, those puncta come together, they create suction, and as we unblink, you hear a little suction sound, and they pull the tears into the canaliculi here, which are the tear ducts, which empties into the nasolacrimal sac, which eventually enters into the nasolacrimal duct and ends up in our throat. Any of you that ever had eye drops, whether at the eye doctor or just used some over-the-counter drops at home, may notice that you get a funny taste in your mouth after you put the drops in, and that is because of this pathway here, right? You put the drops in, those drops eventually make their way. They are vacuumed out by the puncta. They go into the into the upper and lower canaliculi. They end up in the lacrimal sac and make their way into nasolacrimal duct and eventually into the throat. I want you to know the parts of this pathway. So this slide right here, I want you to circle, star, underline, do whatever you need to do to bring this to your attention, because I want you to know the pathway: lacrimal gland, puncta, canaliculi, lacrimal sac, nasolacrimal duct, and eventually into the throat. All right, so there's two divisions to the lacrimal system: the secretory system, which delivers the tears, and the excretory system, which disposes of the tears. Sorry, my computer's been hanging up a little bit. All right, so let's talk about the secretory system, all right, the secretion of the tears. There are 3 layers to the tear film: circle, star, underline, highlight, whatever you need to do, right? This is something that you're going to want to know, not only for my class, but for any other tests you might take down the road, contact lens or the NCLE, maybe even the ABO. But anyway, these are important things to know. 3 layers of the tear film. Let's start with the layer closest to the eyeball, which is the mucus layer or the mucin layer, right? That's the layer that's closest to the eyeball. The middle layer is the aqueous layer or the liquid watery layer. And the outer layer is the oil layer. Everybody can picture what oil on water looks like, right? Oil kind of lays on top of the water. It doesn't mix in easily. It kind of forms a film on the surface of the water. And that's what we want our oil layer of our tear film to do as well. So that oil layer is what's going to kind of hold the aqueous layer in place so it doesn't evaporate so quickly. Another thing I want you to put away in your memory bank is the normal pH range of the tear film, which is anywhere from about 5.2 to 8.35. All right, another slide that I want you to be able to memorize and understand. So circle this, start, whatever you need to do. Goblet cells. Goblet cells are located in the conjunctiva. Conjunctiva is the outer covering of the globe itself, as well as the inner lining of our eyelids. The conjunctiva that covers the eyeball itself is known as the bulbar conjunctiva, and the conjunctiva that lines our inner lids is called the palpebral conjunctiva. Remember I said whenever you hear anything referencing palpebral, we're talking about lids. So goblet cells provide the mucin layer or the mucus layer of our tears. The mucus layer is the most inner layer, the layer that's closest to the eyeball itself. That is the mucus layer, and that comes from goblet cells. I want you to know that forward and backward. This one we've talked about a couple times already. The lacrimal gland, located in the orbit, specifically in the frontal bone of the orbit. The lacrimal gland produces the aqueous portion of the tear film, which is that middle portion, the liquid watery layer of our tears. Comes from the lacrimal gland. The meibomian glands, which are situated in the lid, specifically in the tarsal plate of the lid, those are the glands that produce the oil or lipid layer of our tears. That is the outer layer. Remember, oil on water. So you've got the mucin, which is sticky, provided by the goblet cells. Then you have the lacrimal, the lacrimal glands produces the aqueous portion, the middle liquid water portion, and then the meibomian glands secrete that oil, which is the outer layer, which keeps everything intact so that the tears don't evaporate so quickly. All right, these, you got to know it forward and backwards. If I say, where does the oil layer come from? You got to say meibomian glands. If I say, what do goblet cells, or what layer of the tear film do the goblet cells produce? Mucin layer. You got to know this, really important. So there are several ways that we can evaluate the secretory system using the slit lamp biomicroscope. There's something called the Schirmer test, and there's something called the tear breakup time, or T-BUT. Let's take a look at each of these. So the Schirmer test is just a little piece of paper, right? It's like a little filter paper here. It looks just like this, where I'm circling here. And this little notch is where you're going to fold that over to create like a little hook. And then you're going to take that little hook and you're going to hang it on the lateral aspect of the patient's eye. And then you're going to wait for a certain amount of time. And then you're going to remove this little film, and that this blue shading is to indicate how much of that film, that filter paper, did the patient wet with their tears. So you see, let's start with the normal one down here at the bottom. See it wet all the way to 10 millimeters. That is normal tear production. This one looks like it wet to maybe 5 or 6 millimeters. That's a possible shortage of tears. And then this one barely made it to about 4 millimeters, it looks like, and this is insufficient tear production. Schirmer test is going to evaluate, it measures the amount of tears, right? The amount of tears, how much the tear production of the patient, how much tears do they have? As opposed to, sorry, my computer is freezing up again. As opposed to the T-BUT, or tear breakup time. Let's go to that one. All right, this is the tear breakup time, or T-BUT. The T-BUT is going to evaluate the quality of the tears. Schirmer is quantity, how much. T-BUT is quality. What is the quality of the tears? So what's going on here is, this is the patient's eye. This is under cobalt blue lighting, which is a lighting setting on the slit lamp. You instill fluorescein. You take the little fluorescein strip and you instill fluorescein into the patient's eye. You turn on the cobalt blue filter so that you get this sort of greenish film over the eye. You ask the patient to blink. Blinking does what? Blinking puts a fresh layer of tears over the surface of the eye. So when this patient blinked, we ask them, after they blink, to hold their eye open, to resist the urge to blink, and then we start to count. 1, 1,000, 2, 1,000, 3, 1,000. And if you see here where my pointer is, you see this dark spot forming here and up here. These are areas where the tear film has already started to evaporate. These green areas is where the fluorescein in the tear film is still intact. The dark areas are where it has begun to evaporate. So when we count until we start to see the very first sign of these dark spots or evaporation, that is when we stop. So if we see these, if we're able to count to 10 seconds before we see any dry areas forming, that is a normal tear breakup time result. Anything under 5 seconds is going to be meibomian gland dysfunction. Okay. So let's think, why is that a meibomian gland dysfunction if the quality of the tears is not good? Think about that to yourself for a second. So meibomian glands do what? What part of the tear film do the meibomian glands secrete? That's going to be the outer lipid layer, outer oil layer, or lipid layer, whatever you want to call it, right? The lipid layer or the oil is what's going to hold the tears in place. It's going to hold the aqueous part of the tears in place so that it doesn't evaporate so quickly. So if we have someone with a really a deficient tear breakup time, we know that they're not getting the proper amount of oil mixed into their tears, so their tears are evaporating quickly. So if I back up here, Schirmer test is a test of quantity. This is a test of the lacrimal gland, right? The lacrimal gland up here in the frontal bone is where the aqueous part of the tears is formed, the volume of tears, right? So when we're doing a Schirmer test, we're actually testing whether or not the lacrimal gland is working properly. When we do a tear breakup time, we're testing the quality of the tears, which is what? A function of the meibomian glands, okay? Just kind of make these notes for yourself as we're going along on your slides, and you'll do fine. But these are the points that you need to know about the tear film and the lacrimal system. All right, so ways that we can evaluate the excretory system, which is the way the tears drain out. We can do something called dilation and irrigation. This occurs when we take a little instrument and dilate the puncta, and then we use a syringe with a little attachment with saline, and we place that into the puncta, and then we slowly, depress the plunger, and we push out, we irrigate the whole, the canaliculi, the nasolacrimal duct, and that whole system there. So if there's ever a blockage, we can break that blockage loose by doing an irrigation. We can also do something called a Jones test, and I'll explain what that is. So we instill fluorescein in the eye. Again, fluorescein is that bright yellow dye that we put in the tear film. So what we do is we instill the fluorescein, we wait a little bit. Now remember, let's think back to that slide that I told you to circle and underline and highlight. Put fluorescein in the eye, where's it going to go? It's eventually going to, as we blink, it's going to make its way over to the medial aspect of the lids. What's located at the medial aspect of the lids? It's going to be that upper and lower puncti, the little holes, the puncta, I'm sorry. They are going to cause suction, and it's going to pull those tears with the dye in it into the upper and lower canaliculi, eventually into nasolacrimal duct, and eventually into the nasolacrimal sac, and eventually into the throat. So Jones test is you instill that dye, you wait a little bit, and then you have the patient blow their nose and then show it to you. Lovely. If you see dye, if the dye comes out of their nose when they blow their nose, everything is great. It means everything is working properly. Okay, if they blow their nose and you don't recover any dye, then we know that somewhere along that path there is a blockage or an obstruction. Dacryocystography is imaging of the nasolacrimal system. This is something that can also be done. We're not going to talk about that too much, okay? So again, with this here, with these tests, your take home is, if we're talking about quantity, we're talking about the Schirmer test. If we're talking about quality, evaluating the quality of the tears, we're talking about T-butt. If we're talking about the Jones test, we're talking about the excretory system, how the tears leave the eye. Oh, I'm sorry, I skipped these slides. Here they are. All right, so take a look at these. Tears go through the puncta, they flow through the superior and inferior canaliculi. The canaliculi meet at the lateral wall of the lacrimal sac. Inferior to the lacrimal sac is nasolacrimal duct. The duct opens into the nasal passage. This is why when we blow our nose, we can recover that dye. And then from here, the tears drain into the back of the throat. This is another reason why when we cry, how many people cry and their nose starts running? No, it happens to me. I think it happens to a lot of people. And this is why, right? Because of this whole path here. You're crying, you got a lot of tears, overabundance of tears making their way through the puncta to the canaliculi, to the lacrimal sac, to the nasolacrimal duct, and opening into the nasal passage, and your nose starts to run. And here's a diagram that I skipped, I'm sorry, of that whole pathway, okay? And this is why the Jones test is very effective, right? We instill the dye here, the dye makes its way through the path, patient blows their nose, and the dye comes out of their nose. All right, there is On page 31, there's is a glossary. So familiarize yourself with those terms there. Again, you'll learn. I have no tricks, right? I don't like to trick you on test questions or quizzes. There's no tricks. I really want you to learn this information, and there's a lot of information, as you're going to see. You're going to take a look at some of these slides and think, oh my gosh, I just don't get it. I am going to do my best. I'm going to be here with you through the whole 15 weeks, and I'm going to make sure that I break it down for you so that you see, the main points, the main ideas that I want you to know. And this week, I think I've given you a very good idea about what I want you to take out of this lecture. Okay. At any time throughout the lecture, please reach out with questions, concerns, anything at all. Please remember that this week, you'll want to go and look at let's see. Let me go to the module here. You'll want to go to the modules. We're on week 2 here, and you'll want to make sure that you complete all of these assignments. So this right here is just the PowerPoint lecture, which we just did. Here is a very short article that I want you to read about blowout fractures. And then here is a pretty easy assignment that I want you to complete, okay? So the reading of this article and answering the questions definitely needs to be done by Tuesday, because on next Wednesday, we're going to start another lecture. All right, so I hope this was informative, and yeah, like I said, just reach out with questions or concerns, okay? All right, everybody, have a great week. See you next week.